So first things first, chapter 21, toxicology. This is something that I never really thought about a whole bunch, but every day we do come into contact with things that are potentially poisonous. There are no limit to the amount of things that put into the human body in sufficient enough quantities can actually be poisonous to us. Even things like too much water can have a negative result. Um, Acute poisoning affects way more people than we think of, 2 million people a year. Chronic poisoning is what we would call our chronic drug or alcohol abusers. We have a pretty simple way, if you think about the fact that just about anything can be poisonous to us. We have a pretty simple way to get all the answers we can ever ask for when we talk about things like poisoning. And that is to pick up the phone and call poison control. The people that answer that phone, that's their mission in life, is to be able to tell us lay people with the receiving facility we're going to bring our patient to exactly what is going on, exactly what they can expect, and exactly how to treat the problem. One step even better than that is when we tell them what we have and where we're bringing it, they will pick up the phone and call the receiving facility and let them know what we have, that we're coming in, and what they need to do to treat it. So they will be straight prepared, ready to go the minute we walk through the door. So that's something that I'll get the number for you guys, and you can save the contact or whatever when you get in later. But poison control is a huge asset, and is something that you should have at the tip of your fingers in the event of just in case. So much like pharmacology, toxicology is the study of toxic or poisonous substance. Poison is any substance or chemical that can damage the body or impair body function when introduced into a person. A toxin, we talked about this when we talked septic shock, is any poisonous substance produced by a bacteria, animal, or plant. We will talk venomous animals and poisonous bites and stings a little bit later on. Those are things that, believe it or not, we do have here in the New England states. Massachusetts is no different. There are a couple of types of poisonous snake here in Massachusetts, not to mention any one of a number of spiders and all sorts of other bitey, stingy kind of things. And not to mention the fact that there is a pretty significant exotic pet trade in the Americas. So we really could run into just about anything. I grew up in a town not too far from here, and I think when I was, I don't know, young teens, a guy had a pet king cobra that had escaped from his house, and they found it about a month later in the local elementary school basement. So it's not unheard of to have all sorts of nasty, creepy crawlies kind of kicking around. Substance abuse and misuse is just that, the use of any product other than the recommended dosing and recommended reasoning to produce a desired effect. That desired effect is generally some form of intoxication. And then last but not least, we'll talk overdose here. Overdose is something that you guys will respond to a whole bunch. We'll talk at length probably today when you come in about Narcan, and I think we already have a pretty decent understanding about the hows, what's, when's, where's, and why's as far as Narcan administration goes. They give us a couple of different things that will help us figure out the signs and symptoms and what somebody has been poisoned by. This is really just a visual breakdown of that whole toxiderm thing that I put on Tavuti for all of you guys. I find the videos way more helpful than just having to read this slide. This is actually in your book. Opiates, pretty simple, right? We know an opiate is a central nervous system depressant. We know an opiate is going to turn off all of our important body functions. It's going to alter our patient's mental status. If it's depressing the central nervous system, they're going to breathe slow. Their heart rate's going to be slow. We're going to have those pinpoint tiny little pupils, and our patient's going to be hypotensive. The hypoventilation and hypoxia are generally eventually what kills our opiate overdose patient. They just go from respiratory depression to hypoxia to respiratory arrest, and it follows that general pattern. That's why when we ventilate our opiate overdose, we're really doing the best medicine for that patient, even above and beyond administering Narcan. Our sympathomimetic is something that mimics the central nervous system. It mimics the sympathetic portion of our nervous system particularly, and that is going to excite everything. So something that's a sympathomimetic is going to have hypertension, tachycardia, big, wide, blown open pupils, up to and including things like agitation, really like aggressive altered mental status as opposed to our sleepy opiate patient. And they could be stimulated to the point of seizure and hyperthermia from the constant muscle contraction and constant movement. Sedative hypnotics. We're thinking sedative, we're thinking hypnotic. Which do you think this is going to be more like, our sympathomimetic or a depressant?
Depressant.
Yeah, it's going to be a depressant. So we get our altered mental status, up to and including complete sedation and coma, hypoventilation, hypotension, sedative hypnotics, things like whatever the favorite Xanax, Klonopin, Valium, whatever the favorite is of the month. Narcan's not going to be effective on this. Narcan is simply meant for our opiate overdose. There's no real good way to reverse a benzo overdose or a benzo patient's negative results of their drug use in the field. Anticholinergics and cholinergics, they are more accidental type poisonings. If you look at what some of these things are, we have medicines like Dramamine or Benadryl or atropine, which is a cardiac drug, in our anticholinergics. And they're still stimulating things. They're speeding things up. Tachycardia, hyperthermia, hypertension, dilated pupils, dry skin and mucous membranes. Why do you think they're drying things out? What do we typically think of using things like Benadryl for?
Antihistamine, allergies.
Yeah, an antihistamine, an allergy. It's the job of these anticholinergic meds is just that. They're going to decrease the amount of secretion. Moving right along, we'll talk cholinergics a little bit. Cholinergics are now, we are getting about as far away from our accidental poisonings as could possibly ever be. Unless we're going to talk organophosphates. Organophosphates, a lot of things used on farms to kill insects and sort of increase the growth rate and potential of a farm crop are organophosphate based. So, you know, and I'm not thinking there's a whole bunch of farming going on in the city of Everett, but if we worked out in, say, the western part of the state, you could see something like that. But cholinergics a lot of the times are things like nerve gas and chemical attacks, and they cause the opposite of our anticholinergics. So our cholinergics are going to cause this sludgeum that you'll see in the book, and I'm sure you will see things related to this again, but salivation, lacrimation, urination, defecation, gastric upset, emesis, and muscle twitching. So our anticholinergics, hot, dry, and fast. Our cholinergics, leaking from everywhere, is basically the way to think of those two things. So if we think anticholinergic poisoning, think of everything hot, dry, and excited. If we're going to think cholinergic poisoning, we're going to go the exact opposite. And this is a patient who is just oozing. They're going to have, their eyes are tearing, they're salivating, they're sweating. They are just covered in their own mess. Their stomach is upset. And we see pinpoint tiny little constricted pupils. Spludgem, that's a great mnemonic. The way to remember what each of those means is going to just be rote memorization. So when we're dealing with a poisoning, we want to try and get down to the root of what is causing this problem. So what did you take? When did you take or become exposed to it? Why do you think that's probably important?
For the hospital. So we know how long, like how far into the digestive system it is, if they, or how long the body's been absorbing it, I guess.
Bingo, that's exactly what I was looking for. So how long has it been available for our bloodstream to be picking this crap up and transporting all to wherever? How did you ingest it's also going to be important for downstream sort of stuff. Because if a patient injected whatever it was that they got into their person as a toxin, it's going to work a lot faster than if they put it in their stomach. Not to mention the fact that if somebody has some form of injected toxin in them, it's going to do the hospital no good to put in a tube and start pumping out their stomach if it's not there. Did you have anything to eat or drink? Have you been given anything? Weight is also going to be a big one because, as you'll find out, the deeper you go into medicine, um, a lot of medicine is dose specific and weight based. So how much person there is going to depend on how much medicine is given or how much anything is given. So how much poison is going to be no different. How poisonous will this be to a person depending on how much they weigh? And then when the hospital starts thinking of how are we going to treat this, how much medicine are we going to give this patient based on how much they weigh? If we can't get that information from the patient, well, we go to medical detective again. We're going to look around and see. If we find something suspicious, we bring it with us or at least take a picture of it. Look for any containers on the scene, examine if they vomit, look for any pill fragments. Anything that sticks out to you as important is probably going to be important. What's something that you, just knowing what you know already, think about this patient's condition. How's this patient likely to progress, even if they're doing okay when you get to them?
We're still going to head south.
Yeah, they're going to head south, and God only knows how deep south they're going to get, because the more time this is in the body, the more exposure the body's getting, and the more exposure the body's getting, the more negative the results are going to become. Our poisoning patients are really just a mixed bag, right? We can have a patient who seems perfectly fine, perfectly stable, and like somebody threw a light switch, all of a sudden their body absorbs a whole bunch of whatever the chemical is, and they go to pieces in a hurry. We may be, again, the last person that ever gets to speak to this patient until days, weeks, ever. And knowing what was leading up to them heading south and possibly heading south fast is going to be important for continuity of care and the patient actually hopefully getting better. These patients, for sure, you should be prepped and ready for some airway compromise, some respiratory compromise, anything and everything as far as mental status, airway, breathing, and circulation go. So being ready and just sort of expecting the worst and crossing your fingers for the best is going to be your best course of action. Treatment for sure depends on how it got into our person. The four main routes of a poison entering a person are going to be inhalation, absorption, ingestion, or injection. Inhalation, pretty simple. Absorption can be a bit more difficult to discern. That's how some of those organophosphate poisonings actually happen. You'll have people that are out working in an area where those organophosphates are being used, and days, weeks, months, years of being exposed to this certain chemical, it begins to build up into their system, and they will wind up with long-term toxic exposure turning into an acute toxicological problem. Ingestion and injection also pretty straightforward. So here we have on the upper left our inhalation, on the upper right we have our absorption, on the bottom left we have ingestion, and then we have injection on the bottom right. So let's start with inhaled poisons, and we'll operate under a little bit of common sense here. First and foremost, move the patient to fresh air immediately. That's going to be beneficial for two reasons. The first and most important is whatever is poisoning this patient could also be poisoning you. So get them out of the area, get them out into fresh open spaces. The patient may or may not require supplemental oxygen. If you think there's some sort of toxic gas present, activate a hazmat response. This is requesting our additional resources. Everyone who has inhaled this poison requires immediate transport. There's no hard and fast rule as to how much is too much. It is very body specific. So everyone should go and get evaluated. One of the things to be on the lookout for is inhaled poisons in a suicide attempt. Exhaust fumes are high in carbon monoxide. It does not take much carbon monoxide to interfere with our body's ability to transport oxygen. Carbon monoxide binds way more efficiently and way stronger to the red blood cells than oxygen does. If it is a carbon monoxide poisoning, we generally will see things like the person has sealed off wherever they're going to leave this engine running so that it doesn't spread throughout the house. Generally, there will be something either clogging the exhaust pipe so the fumes back up into the car faster, or a hose from the exhaust pipe to the inside of the car. That is not to say that this has made a safe environment for you. If there's no way to ventilate and get that carbon monoxide out, don't go in. Another one that has gained some traction in recent times are these chemical suicides with different kinds of detergents. It's really simple to figure out how to make these kind of things. A lot of times they'll do them in a vehicle because it's a smaller area, it takes less chemical. The good thing that people that do these kinds of things do for our benefit is a lot of times they will put some sort of sign or some sort of indicator telling us not to open the door, because it is possible to be immediately overcome by these fumes and you wind up being collateral damage. There won't be any real saving of this patient if they've chosen to do a chemical suicide in their vehicle. So don't turn yourself into just another victim. Contact the hazardous materials and they will get the patient out, and whatever happens from there happens from there. We work it like a normal cardiac arrest and all that good stuff, but don't get yourself caught up in the wash. When we talk absorbed poisons, many different things that they can do. We can have damage to the skin, mucous membranes, or eyes. Absorbing chemicals through the skin, the mucous membranes, or the eyes is almost as fast as injection. So it can be into your bloodstream and pretty systemic rather quickly if a chemical has been absorbed into these mucosal membranes. You may see contact chemical burns on the patient's skin. You can see things like rashes and any and all sorts of systemic effects when a poison has been absorbed. The skin is a barrier, yes, but it is not a one-way barrier. Sometimes things do get absorbed into the skin, and it can be pretty quickly moved throughout the body and cause widespread effects. As far as signs and symptoms go, we're going to do all of the same. The history of the exposure, what was it, how long, anything associated with that getting on you, because we don't really know the absorption rate. We don't know how long it was there unless we ask. Do you see any liquid or powder or evidence of burns or skin irritation and itching? Do you smell anything? Our treatment is going to be pretty straightforward for surface contact poisons. First of all, we want to avoid contaminating ourselves for any others. Secondly, we want to get this off of the person as fast as humanly possible and as effectively as humanly possible. We want to remove all contaminated clothing. We want everything off of this patient that's even possibly gotten this chemical on it. If there's a powder, we want to go ahead and brush as much of that off as we can. Some things will actually have a pretty violent reaction with water, so we don't just go immediately to flushing if we see powder chemical on somebody's skin. After we have gotten as much of that powder off as we can, we want to flush with water for 15 to 20 minutes and then wash the area with soap and water. Soap is actually pretty good at deactivating a lot of things, especially if we've diluted it for long enough. If it is just a liquid, straight 15 or 20 minutes, it's already a liquid, so the water is not going to react to it as negatively. We just don't want to activate our dried powder type chemicals. That's for the skin. The eyes are a horse of a different feather. If it is contact with the eyes, we want to begin irrigating those eyes right away, right away, right away. Why don't we worry about whether it's a powder, whether it's a liquid, regardless of what it is, we just go right to flushing as much of that out as we can.
Because the eyes will probably most likely absorb it faster.
Yeah, and the eyes are already wet. So if it's already getting absorbed and it's already going from that dry powder to a more liquid type of form, it's going to get in quicker. It's going to do its damage faster. The eyes are very, very sensitive to this sort of thing. So getting as much water running through those eyes as humanly possible, as fast as humanly possible, is going to be the order of the day for poisons when they get into the eyes, whether they're dry chemical, wet chemical, makes no difference at all. If we're talking about an industrial accident, we should have a lot of information available to us pretty quickly. There are supposed to be any place where large volumes of chemicals are stored, there's supposed to be safety showers. The specific treatment protocols should be available to you. The material safety data sheet should also be available to you so you know what the chemical is, what kind of damage it will cause. You should be able to bring that information to the hospital with you, either in picture form or in actual physical form. They should be able to make a copy of that for you so that you can start setting your treatment priorities. You can know what to expect from what this patient has been exposed to. There are supposed to be hazardous materials people on scene when we talk large chemical problems. Most importantly is keep yourself safe, keep whatever is damaging this patient, you don't need it to be damaging you, and make sure the patient is thoroughly decontaminated before they go in your ambulance. Because once a contaminated patient gets into your ambulance is contaminated, you're contaminated, the patient is still contaminated, then you're going to bring a contaminated patient to the emergency room where the spread of this contamination just continues to grow and grow and grow. And we turn what should have just been a one-person problem into our problem and lots of others as well. So this is something that I found pretty crazy, that 80% of poisoning is done by mouth. That seems like a really high number to me. When we talk about the differences between adults and children, children put everything in their mouths. They don't know enough to know that things that go in their mouth can hurt them. Generally, poisoning in children is accidental, whereas adults will do it on purpose. Our signs and symptoms and the way all these problems are going to present are going to differ depending on what the type of poison was, how old the patient is, and how long has passed since they put it into their body. Type of poison especially is going to be important for us and medical control and poison control when we talk ingested poisons, because our signs and symptoms are going to vary. We could have burning to the airway. We could have lots of airway compromise possible. There could be some gastrointestinal pain. There could be some vomiting. We could also start to see some problems with cardiac, mental status. Depending on what this poison is and how negative its effects can be, is going to sort of tell us how bad our patient's going to get. But if we talk airway burns, vomiting, what burned on the way down is going to burn on the way up. So we're going to have more burns to the esophagus, more burns to the airway. If we have more burning going on in portions of our patient's airway, we can start to talk now more swelling, more inflammation, more stridor, more compromise, more tenuous of an airway. And then our patient is having cardiac problems and seizures. So now airway problems, respiratory problems, circulatory problems, mental status problems, and the scope of sort of disaster, dirty, ugly call gets a bit bigger and bigger and bigger. We aren't going to effectively be able to treat these in the field. Our treatment is going to be transport and knocking out signs and symptoms as they present. Get on the phone with poison control. Absolutely. I think that's a great resource in situations like this. Now, this is where National Registry and the curriculum in the book is a bit different than here in the great old Commonwealth. We do not carry activated charcoal any longer. Activated charcoal is a medical control option 100% of the time, because it doesn't work with a lot of ingested poisons. So activated charcoal is, I believe the dosing on it in the book is 1 gram per kilogram up to 50 or 25 grams. I forget what the whole bottle is. Let's see if we can see here. Yep, 1 gram per kilogram up to a total max dose of 50 grams. But you are always going to call medical control if you are ever in a situation where activated charcoal is your option. So think testing scenarios. In Massachusetts, we don't carry this anymore. Why do you think that might be?
Hospitals are fairly close to us compared to other places.
Spot on. You can't swing a dead cat around here without hitting a hospital. So there's no reason for us to carry something that either may or may not work. And if you've ever seen this stuff, the odds that you're going to get somebody to drink this and keep it down are almost non-existent. It is gross. It is black. It looks gross. It tastes gross. And we physically have to get them to drink this and keep it down. Because if they can't keep it down, we're just going to cause vomiting. And if we cause vomiting, what burned on the way down is going to burn on the way up, plus airway compromise. And it is just feeding and perpetuating the negative cycle and not helpful.
Now, Tommy, is this going to be on the national or?
This will be, yeah.
Okay, thank you.
And like I said, the dose was right, 1 gram per kilogram up to 50. And the reasoning behind using it and when we can, it's a medical control option, so you got to call the doc, and it's for ingested poisons.
Okay, got it. Thank you.
Yep. Injection, also pretty simple. It can be IV drug use. It can be envenomation by insects. Let's see, arachnids and reptiles. So they're talking insects, spiders, and snakes. Usually it is very, very quickly absorbed into the body. Once it is in the body, can't be diluted, can't be removed. We can see just about anything. You know, heroin is an injected poison. It's going to operate inside the body a whole lot differently than our patient who is stung by a bee or our patient who is bitten by a rattlesnake. It's going to depend on the kind of poison. But our treatment priorities are all going to be the same. Monitor the airway, provide oxygen, be alert for nausea and vomiting. Nausea and vomiting is likely to occur. We want to remove anything that's constricting around the injection site. How come?
You're gonna swell up, right? So like a ring will, if your finger swells, the ring is gonna cause an issue.
Yeah, what kind of issue is it likely to cause?
Circulation issue?
You got it. That's exactly the reason we remove just about anything and everything we can from that particular extremity, because we expect swelling. We expect tissues to be aggravated and irritated and begin to swell. So if we know ahead of time that they're going to swell, we do our best to beat that swelling because we don't want the associated circulatory compromise. Take your standard precautions. Scene safety, BSI should always be in the forefront of your mind. As I'm approaching, is there an odor? If there's an odor, it's time to leave. The scene is not safe. Do we see anything laying around? Do we see things that make us concerned? Do we see beer bottles and stuff everywhere, drug paraphernalia? Believe it or not, this whole drug laboratory thing is a bit more local than we would imagine. As far as drugs of abuse go, people can make methamphetamine in a Poland Springs bottle. So it's not this big like Breaking Bad contraption thing that you're thinking of when most of the time you think of large scale drug operation. Methamphetamine can be made in like a 20 ounce or 1 liter Poland Springs bottle with no problem at all, except for one teeny tiny little thing. Anytime somebody is making methamphetamine, it turns the entire building into a hazardous material site because the crap that goes into that is all hazardous materials and then they mix them together. Most of the time, our people who are going to be operating a drug laboratory, they're not chemists, they're not pharmacists, so expect dirty, nasty, rotten, awful conditions and don't be there. But now we're talking primary assessment of our patients, so we've moved on. Our scene size up past our threshold for saying, okay, this is safe. We want to get our general impression. Of course, as always, we're going to follow our primary assessment right through all the steps. General impression, level of cautiousness. So Larry, and Larry looks at me and he's talking to me normally. Cool, I know Larry's alert. I'm going to ask him his orientation questions now. Do you know who you are? Do you know where you are? Do you know what day it is? Tell me what's going on. Going to check and make sure that there are no obvious life threats. Just because somebody has an adequate level of consciousness does not mean they are a stable patient, does not mean that they are doing well or they will continue to do well. Always suspect airway, breathing, and circulation to be a problem if you're thinking poisoning. Ensure that the airway is open, clear, and secure. If it's not patent, if your patient's not speaking to you, if they're not conscious, do what needs to be done to make that happen. Expect to have to suction these patients. Begin oxygen therapy, of course, 15 liters per minute, non-rebreather mask. The way a lot of these poisons work is that they're going to interfere with our patient's ability to have respiration occur. It's going to be generally an oxygen problem sooner rather than later. Now, that's not all the time, but it's enough of the time that getting out in front of the oxygen problem isn't such a bad idea. But always have your suction on hand. Skin color, temperature, condition always tells us a lot. Cardiac, we of course rate, rhythm, and quality. These things haven't changed, they won't change. Neither will this. They're going to be a high priority transport to the closest appropriate facility with an ALS intercept en route. Just because someone is presenting to you well at this point doesn't mean they're going to continue to do well. Don't fall into thinking that this is a stable patient. Prompt transport if you found any problems with their level of consciousness or ABCs, or anybody who gives you a kind of a crummy general impression is always going to be the order of the day, regardless of whether it's a poisoning or anything else. If we find problems here, we have someone who factually is not doing the things that need to be done to maintain them as a human. Decon for sure. Don't turn yourself into a patient, ever. Our history is also pretty straightforward. Our signs and symptoms, allergies, medications, pertinent past history, last oral intake, and events. This is not going to change because this is not the history of their present illness. This is their medical history in a nutshell. If we can't get a patient's sample, that's okay. Get it from other bystanders if you can, friends, family, whatever. If they're unresponsive, they're unresponsive. Wanting a sample of history isn't going to help you. But then we get a little deeper into our secondary assessment and we add some things to our OPQRST, right? We want to know what was involved. We want to know how long it's been in exposure, how much, because sometimes just a tiny little speck of some chemical substance on your skin can be pretty detrimental. And sometimes it is just that. It's a tiny little speck of something on me and we just brush it away and irrigate the area and everything's fine. We really have no ability to know all that stuff. It is so far beyond what our capabilities of EMTs are and really what our job is to think that we have to know everything there is to know about toxic exposure. We're going to manage signs and symptoms. We're going to manage the problems as they present to us and be prepared for our patient to deteriorate and get worse. Our focused assessment is going to be just that. We're going to focus on the area or the part of the body involved with the poisoning. Sure, we're going to look at everything in situations like this. Why do you think we start with the area that was exposed and then we start checking under the hood a little bit deeper? Why do you think we look like everywhere on these patients? how does this toxin, how does this poisonous substance get moved throughout the body?
It's throughout the blood.
Throughout the blood, and the blood goes everywhere. So just because we start with the area that was involved doesn't mean that's the only place where we're going to find a problem. So we expand our physical exam out a little bit to see, are we finding systemic issue? Are we finding things that don't make sense in other places? Because that's going to tell us how much exposure is my patient's body receiving. Reassessment, we start back at our ABCs, we move on, we're going to reassess our vital signs, we're comparing them to our baseline set. We're trying to get that patient trend identified, see if they're getting better, see if they're getting worse, see if they are just maintaining and sort of staying the same. I wouldn't call these patients stable. So I wouldn't say this is a patient who every 15 minutes is good enough to recheck their vital signs. Facts are facts, and we don't know. They could be stable 1 minute, dead the next. So constantly chattering with your patient, constantly asking them things, constantly talking to them, and performing a solid reassessment every 5 minutes is really going to be the order of the day with these people, because they can head to hell in a handbasket really quick. Now we're going to talk about some specific type poisonings. We're going to get into drugs of abuse a little bit here. Over time, a person's body not only develops a dependency on chemicals, but it will also develop a tolerance. So you will hear of chronic alcohol and drug abuse patients using just an absolute ridiculous amount of whatever their chemical of choice is. Scene safety and BSI are going to be very, very important here. Don't get a chronic drug abuser's blood on you, in you, anywhere near you if you can avoid it. Wet and sticky and doesn't belong to you, don't touch it. So always wear gloves. If you're talking airway maintenance for someone who has overdosed on a poison, always that face mask and eye shield. We know that people that are chronic IV drug users share needles. So you can have all sorts of different types of infections, including but not limited to things like HIV and hepatitis. Hepatitis being of way bigger concern. Hepatitis is much more stable outside the body and can have way, way, way more likelihood of you actually contracting the disease. The good thing about hepatitis is it's very preventable and very treatable. There's a vaccine for hepatitis A and B, and they are having really good success at treating hepatitis C. An ounce of prevention over a pound of cure. The treatment to cure hepatitis C is not pleasant, so be careful. Anybody out there want to take a shot at what the most abused drug in probably the world, and if not the world, at least the country is?
Alcohol.
Alcohol, indeed. Alcohol is a central nervous system depressant. Alcohol will, in large volumes and chronic overuse, cause damage to the liver. Even not necessarily chronic overuse, occasional heavy use will also wind up being more damaging, believe it or not, than someone whose body has become accustomed to the use of alcohol. Alcohol is pretty much the only drug.
Tommy,
Yo,
my screen is like white.
what did I do?
There you go.
Did I fix it?
Yep.
Yep.
If I hover on the wrong part of the screen, it kills it for some reason. I don't know why. Keep this over here. So withdrawal from alcohol is truly the only actual drug that withdrawing from the chemical can actually kill you. Most of the other ones, yeah, maybe a case of bad luck withdrawing from a benzo, something like Ativan or Klonopin or Xanax can have some pretty negative repercussions, but alcohol is the one. Alcohol develops such a strong actual physical dependency that you may die if you are a chronic alcohol user who tries to quit cold turkey. But at the base, alcohol is a central nervous system depressant. So it turns things down, it slows things down, dulls the senses, slows reflexes. A patient, sure, may they be aggressive and uncooperative, lack of coordination? Yes. But at the end of it, and when we're talking large quantities of alcohol, expect the depressant side. So things like airway, breathing, circulatory compromise. These are the problems that we're going to see. If we want to talk not using anymore, we will talk sort of the way someone who is a chronic alcohol user progresses through drying out and cleaning up. That is the DTs, delirium tremens. This is a patient who has been a chronic alcohol user probably for a period of time, probably for a lengthy period of time. Alcohol is something that is easy to get your hands on, so people will tend to go on long runs of chronic alcohol abuse because up around my way in New Hampshire, I mean, you can go into any store there is and buy beer and wine. Agitation, restlessness, fever, sweating, tremors, tremulousness, the hands just shake. The worse they get and the sicker they are, we'll start to see increases in their vital signs, hypertension, tachycardia, confusion, disorientation, delusions, and hallucinations. I don't know why, but one of the psychiatric doctors I used to work with said that most of the time when someone is withdrawing from alcohol, the delusions and hallucinations are almost always spiders if they're seeing something. He didn't know why. I don't know why, but having seen plenty of people do this, spiders is an awfully big complaint a lot of the times. What we're really on the lookout for is alcohol withdrawal seizures. This is a bad, nasty, real for life looking tonic-clonic seizure where the patient just continues to seize and there's almost no period of lucidity. Maybe they stop seizing and they breathe a little, but they don't really come back around because their body is still withdrawing from this chemical. Patients who are chronic alcohol abusers are really sick, and airway, breathing, circulation problems are just going to be present. Vomiting is very likely, seizing is very likely. This is someone who, you know, is going to require us to be on our A game. And it can happen hours, not even days, after the patient last had a drink. Alcohol is pretty quickly eliminated from the body, and people that abuse it for a long time truly do need it to maintain, I guess, what you would consider normal function. Next, we got opiates. We'll take a 100-foot view on this. What is an opiate?
It's a drug that definitely is like a downer. Naturally comes from a plant. You'd find out towards the Middle East area. It is used in such medicines that are orally taken, prescribed to patients that are going through an injury.
Yeah. What really started this whole opioid crisis back up again because it was bad years and years ago, the 70s. What started it back up was really the prescribing of things like anything on this list. Vicodin, Dilaudid, morphine, Percocet, OxyContin. Years ago, a few years back, pain became a vital sign. And the medical community became almost obsessed with completely eliminating pain. So if you walked into an emergency room and you were in pain, they were going to prescribe you something to take care of that pain. Made no difference whether that pain was a 2 or whether that pain was a 10. Their job was to eliminate that pain. And you would leave the emergency room with a prescription for umpteen hundred Percocets or OxyContins. OxyContin is a drug that was made to become addicted to. It was made initially to treat people who are in the end stages of life, dying from things that are particularly painful. And OxyContin was great at its job, but it was also great at creating addicts. And we wound up with a lot of people who became opioid dependent after taking a prescription. And the math is pretty simple. If your patient is paying $1 a milligram for an OC 80 milligram pill, how much is that pill going to cost them?
And the patient, oh, okay, never mind.
$1 a milligram times 80, that one
Right.
pill is going to cost them $80.
Yep.
I could walk out the door here, take probably one right and a left, and pay $6 for a gram of heroin. Maybe 8 because they don't recognize me. The math is easy. People couldn't afford these pills that they were prescribed anymore, and then the doctors would cut them off. No, your pain must be better by now, so they wouldn't write them any more scripts, which sure, that's a good thing. But they weren't going to go through the withdrawal. They weren't going to go through the actual being of dope sick. They were really addicted to this pill that the doctors had prescribed for them. And then when the doctors shut them off, they started paying $1 a milligram. And that $1 a milligram eventually got expensive. And then they switched to $6 a gram and a dirty needle. Regardless of how they use this opiate medicine, it's a central nervous system depressant. It's going to have respiratory depression. It's going to have depression of my patient's mental status. It's going to have hypotension, bradycardia, and it is really going to turn off the patient's central nervous system. The BVM is going to be what does this patient the most good. Ventilating this patient for that 3 to 5 minutes is going to be important because when we show up, people will probably already have Narcaned this patient. But you'll look around and you'll see nobody is managing their airway and nobody is doing any ventilation, and this patient's breathing 4 times a minute. And they want to know, well, why hasn't he woken up yet? Well, he hasn't woken up yet because his brain is still going off like pop rocks because there's no oxygen in his person for him to even start waking up and becoming a normal person. Narcan will get in. It will reverse the effects of that opiate overdose. It will. It can be given IV, IM, or IN, intranasal. Intranasal Narcan is what we're going to be using as BLS providers. It is a great medicine. It will help. But first, we need to reverse some of the hypoxia. We need to allow some of the other opiate medicines the other doses of Narcan that other providers or bystanders may have given this patient to work. We don't need to just go dumping additional doses into them. So ventilate, ventilate, ventilate. 3 to 5 minutes, one breath every 5 or 6 seconds. You're going to feel during that 3 to 5 minutes like you're not doing what you're supposed to. But what you are doing is way better for this patient. They're not going to wake up as angry. They're not going to wake up as sick. They're not going to wake up as nasty. It is far better for someone to come around slowly and wake up sort of a little bit more peacefully than for us to turn the patient into someone who is in complete and total drug withdrawal and is an angry vomit fountain that wants to fight with everyone. All right. That is that for lecture. And now I'm going to play a video. Just got to get it up here, queued up on the screen.
When it comes to trimming your balls, always use the right tool and job. Manscaped is the only.
So here's the situation. You have a patient on their way to your emergency department, and EMS tells you, 35-year-old male found down and unresponsive. There was a white powder found next to him on the scene. Possible overdose. Blood pressure 90s or 50s, heart rate 60s. Patient is breathing very slow. We're backing him now. ETA 3 minutes.
All right. Did you guys catch that radio report?
Not too clearly, no.
All right, hang on. I'll turn it up.
so here's the situation.
Whoa.
You have a patient on their way to your emergency department, and EMS tells you, 35-year-old male found down and unresponsive. There was a white powder found next to him on the scene. Possible overdose. Blood pressure 90s or 50s, heart rate 60s. Patient is breathing very slow. We're backing him now. ETA 3 minutes.
Well, that must have been better because it nearly blew me out of my chair.
Yeah, that was good.
All right. So, blood pressure, high or low?
Low.
Low.
Heart rate, high or low?
Low.
Low. All right. Mental status, same question.
Unresponsive.
Unresponsive. And respiratory rate was slow, and they're assisting ventilations. So we got a couple of things this could be, right? So far we've talked sedative hypnotics, things like Xanax and meds like that, or an opiate. So if we're thinking things that are turning the central nervous system off, we have some pretty good information so far. Let's see how the rest of this plays out.
in a situation like this, you need to think fast and know your common toxidromes, because pattern recognition in this situation could save this person's life. So let's talk about toxidromes. What is a toxidrome? A toxidrome is actually the combination of the words toxic syndrome. It was coined sometime in the 1970s by two pediatric physicians in an article titled "The Unknown Poison." The quote went along the lines as this:
some common combination of manifestations, which we have termed toxidromes, can give a clue to the drug involved.
In other words, toxidromes are used to describe groups of signs and symptoms that result from particular poisons. So let's break it down into the most common toxidromes: anticholinergics, cholinergics, ethanol and sedative hypnotics, opioids, and sympathomimetics. And yeah,
Hang on, I'm pausing this to do a bit more stealing.
I know this looks like a lot of information, so why don't we break it down and go one by one. So with anticholinergics, things like atropine, physostigmine, and diphenhydramine, the patient's blood pressure may be normal or elevated. They are tachycardic, respiratory rate can be variable, and their temperature would be elevated. Their mental status would wax and wane, their pupil size would be large and bowel sounds decreased, and you could expect this patient to feel warm and dry. Additionally, you would notice dry mucous membranes and possibly a large filled bladder retaining urine. With cholinergics, things such as the organophosphate pesticides, the patient's blood pressure and heart rate are variable, but you may see these patients breathing very fast. The patient's temperature is also unchanged. The patient's mental status will be depressed. Pupil size may vary, but bowel sounds would be hyperactive. You could think of these patients as secreting liquid from their body because they will be sweating, salivating, crying, urinating, having diarrhea, etc. With ethanol and sedative hypnotics, things like the benzodiazepines, your vital signs are typically all depressed. Mental status is also depressed. However, in the early stages, these patients may experience some agitation. The patient's pupil size can vary, bowel sounds decrease, and these drugs really have no effect directly on the skin. Another finding on physical exam is if you have these patients walk, they are typically ataxic. With opioids, things like hydromorphone, heroin, morphine, these patients' vital signs will typically be depressed across the board. Their mental status will also be depressed or even sometimes unarousable. These patients will have small pupils or classically described as pinpoint pupils. The patient's bowel sounds will be decreased, and you also may notice that these patients may be hyporeflexive. With sympathomimetics, things like amphetamines and cocaine, the patient's vital signs will be elevated across the board. In terms of their mental status, they will be very agitated or even aggressive. Their pupil size will be very large, bowel sounds hyperactive, and when you go to touch these patients, they'll be sweaty and moist. And because of their agitation, they may even have a slight tremor. And I know I included seizure at the end of sympathomimetics, but with any of these drugs at very high doses, it could lead to seizure, coma, and death.
So that is about as straightforward as it gets. Those are the most common things we're going to see as far as poisoning goes. And that was about as concise of a description as to what we can look for with them as you can expect. I know the book goes into great painstaking detail, so does the lecture a little bit, but really at the end of it, there's your information. And I will make sure to share that stuff with you today before you get here. I'll have something worked out, and I'll actually put this video up too because this was really good. Anybody have any questions?
So here's the situation.
All right, if there's no questions, why don't we take a break and we will get into our environmental lecture. And after that, it'll be roundabout time to start heading this way. So let's see, I have 9:45. Why don't we say 10 o'clock we'll come back. I'll put 15 minutes up and we will get into our environmental emergencies. That work?
Yeah, sounds good.
All right, I'll see you guys in a few. All right, fellas, I'm back. Sorry, I was a couple minutes late. I was putting that video up so that you guys could have it for future reference if you wanted it. What we're going to talk about now is chapter 32 and environmental emergencies. This is where we are going to cover some of the, venomous bites and stings, but for the most part, we're going to cover too hot, too cold, and what to do with those patients. So we've talked pretty lengthy here about our different populations, right? And the people we expect all sorts of different medical emergencies to affect more. And what you'll see here is environmental type emergencies is absolutely no different. Children and old people, they still don't have the same ability to overcome hot and cold, being bitten or stung by something, being struck by lightning, quite as well as people in the mid-range of life where your body's supposed to be operating at its optimum point, where things are supposed to be clicking along very, very well. And we will see more negative reaction with the body to any of our environmental causes. These are all of our things that are quote unquote environmental emergencies. So heat and cold related emergency, water emergency, pressure related injuries, injuries from lightning, and last but not least, envenomation from any of the poisonous little slithery, creepy crawly things that may bite or sting. Some factors to be on the lookout for, obviously physical condition. The better shape someone is in general, the better their body is going to be able to compensate for and overcome things like hot and cold, even lightning strikes to a certain degree. If someone's cardiovascular shape is very, very good, it's much more likely that we will be able to help them along the path of return of spontaneous circulation, or maybe not even find them in cardiac arrest after a lightning strike. Infants, children, older adults, they are much more likely to have negative consequence to really anything, and our environmental factors are the exact same. Add to that, people who aren't hydrated or aren't really taking care of feeding their body the way that they need to, and you can see how one problem just leads to another and perpetuates the negative cycle. So some things make environmental problems better, some things make environmental problems worse. Keep in mind that if the area where your patient is found is so cold or so hot that it has created a negative circumstance for them, it's also entirely possible that it will create a negative circumstance for you. So removing them from the environment can help to improve both their problems and help to make sure that you don't get any. Extremes in temperature and humidity are not necessary to produce problems with a patient who is either hypo or hyperthermic. You do not need to be out in 100-degree weather in 100% humidity in order to wind up having things like heat cramps or heat exhaustion or heat stroke. And the same goes for hypothermia. You don't have to be out in 5-degree temperature or 10 below temperature in order to start seeing some of the negative bits and pieces that go along with hypothermia. We're going to start with cold exposure. Cold exposure, generally, we look at it in categories, right? First things we expect to see with exposure to the cold really getting some damage are going to be areas that are typically exposed. So you start to think the nose, the ears, maybe the hands. Then we start thinking about the feet because of the different ways that the body actually loses heat. So we have all of these 5 different ways where the body is going to lose heat to the surrounding environment. Conduction, that means direct contact. You are directly in contact with something cold. Convection, wind will actually increase the amount of heat lost from the body by 10 to 15%. So on a cold day that's windy, you're going to lose heat from your body 10 to 15% faster than just on your average cold day. Add to that things like evaporation. The body's normal mechanism for cooling itself is sweating. That is cooling by evaporation. If you're out doing a whole lot of work, shoveling the driveway or cleaning off the roof of the house on a day that is cold and windy, that evaporation is actually now cooling you down as well. You should never be outside on a day that is freezing cold and be either so worked up that you're sweating or so well dressed that you're sweating, because you're actually causing a negative instead of a positive. Radiation isn't radiation like you think of, that makes the Hulk. Radiation is heat just moving away from the body into the environment. And then last but not least is respiration. Respiration really does just mean that, the act of breathing. When air leaves my lungs, it is round about 98.6 degrees and full of carbon dioxide. I am going to blow 98.6 degrees out into the environment, and when I take a breath in and I ventilate and I get all that gas down to my lungs, it is whatever the temperature of the ambient air around me is. So I'm cooling myself now from the inside out. So all of these things are what the body has to try and overcome in order to maintain body heat in a cold environment. Some factors that are going to support a patient in hypothermia are the body is first going to attempt to increase its own heat production. What do you think how does the body do that?
By shivering.
There you go. Shivering is the first mechanism that the body uses to try and increase its heat production. It's constantly moving, it's constantly twitching those muscles and causing the shivering that is constantly generating heat. You're also, whether you know it or not, going to be stimulated mentally to move to an area where heat loss is going to be either increased or decreased. So in this point, we are talking about cold, so your body is going to drive you. Your brain is going to push you to get out of the cold. When you have that, tiny little voice telling you it's probably time to go in, it's probably time to go in. And the last little bit that's going to help your body overcome cold weather, well, dressing appropriately. Dress in layers. You want to have something that's not going to allow for moisture to maintain on your skin. You want to try and make sure that you are keeping the wind from blowing through you. You want to try and limit the amount of cold that is actually being introduced towards the core of your body. Because hypothermia actually occurs when the body temperature falls below 95 degrees. When the body falls to this, and this is core temperature, that means your external pieces, the distal parts that the brain it doesn't really care altogether that much about, has already been in hypoperfused state. It is already tried to shunt all of that blood towards the core of the body to keep it warm. And now those mechanisms are also beginning to fail. The body actually now is losing its ability to regulate heat and temperature. Shivering stops. And if shivering stops, the body's not generating any more heat either. And then we start to see things begin to slow down. Your heart rate starts to slow down. Your respiratory rate starts to slow down. These patients, a lot of times when they are in a hypothermic state, maybe frozen near to death, will appear as if they are actually dead. Why is the old saying, you're not dead until you're cold and dead, very appropriate though? I mean, until you're warm and dead. Look at some of the things that we talked about slowing down. Heart rate slows down, respiratory rate slows down. Those are all things with the biggest metabolic demand, right? So they need a constant supply of oxygen and glucose, very susceptible to not having it. So one of the things that the body does is it slows all of these things way down. That's why when we were first talking about vital signs, I said your patient who's hypothermic and looks frozen and may look dead, we're going to check their heart rate and their respiratory rate for a full solid minute, because it's entirely possible that their body's metabolism, their metabolic demand has been decreased to the point where their heart rate has slowed down, their respiratory rate has slowed down to nearly dead, but it's only because they're cold. You can actually bring these people to the emergency room and warm them up. And when they warm up, their heart rate comes back up, their respiratory rate comes back up, their mental status improves. Now, they may have some tissue damage because fingers and toes and hands and feet and things like that have been frozen for a really, really long time. But these patients will, a lot of the times, wind up coming back. So we always are going to bring and treat our hypothermic patient like they are a salvageable patient. One of the things to keep in mind is they are very susceptible to going into ventricular fibrillation and actually winding up needing to be worked as a cardiac arrest. So we have to handle them very gently. You know, be careful with any bumps, any bruises. As I said before, air temperature doesn't have to be below freezing. People that are in the cold for a long period of time, think homeless people. They don't have the ability to ever be warmed up. People whose homes don't have heat or can't afford things like oil or propane or with natural gas, whatever, they are constantly in a state of cold. So they are constantly losing heat to their environment. Same with swimmers. I haven't found any water around here that was 98.6 degrees. So if you are in cold water for an extended period of time, that cold water is going to soak any of that warmth that it can away from your patient, and it's going to dissipate into the water, and your patient's going to begin to become hypothermic. Some of the signs and symptoms to be on the lookout for, the colder somebody gets, the worse off that all this is going to be. Let's operate with some common sense here. Obviously, the more chilly someone is, the more likely it is we'll start to see loss of coordination and some muscle stiffness at more reasonable body temperatures. As we get a little bit lower, we'll start to see that some of the body's failure mechanisms have begun to maybe not work so well. We have the constricted blood vessels, we have slowed respirations, and our level of consciousness as the patient goes and gets colder and colder and colder is going to just continue to get worse and get worse. If you look way over here on the right-hand side of our chart, we have apparent death, cardiac arrest, and unresponsive. So be really careful handling these patients, because sending them into cardiac dysrhythmias and ventricular fibrillation and cardiac arrest is quite likely. We a lot of times will see patients who, for one reason or another, when they are exposed to particularly cold temperatures, wind up less clothed than they were when they left the house. That confusion at 89 to 92 degrees Fahrenheit will actually sort of start playing tricks on our patient, and they wind up starting to shed their outer layers because for whatever reason their body tells them that they are warm. It's a coping mechanism. That just helps them to get sicker and sicker and worse and worse. If we find a patient who is very, very chilly, it's no longer good enough to do that skin color temperature condition check on the exterior or peripheral portions of our person. We're looking to see what their core feels like. We want to know how close is their core body temperature to what it should feel like. We don't carry thermometers, but here is some just FYI type stuff. Mild hypothermia, 90 to 95, and severe hypothermia is less than 90. I've come to figure out over the years that when they give you information like this, it is entirely possible that you will see it again. I don't know why EMS testing likes to give you everything in degrees Celsius as well, but 32 to 35 for mild hypothermia, below 32 for severe. So now let's talk some localized injury. This is what localized cold injury looks like. This is our frost nip, or maybe progressing into some frostbite. We see on the right, we had probably some, I wouldn't think exposed feet, but these were feet that were probably wet and cold for a particularly long time. If we look at the nose in the middle and our fingers on the end, these are some of the places where we will generally see problems beginning to develop first, because these are our areas that are going to be more exposed. Our localized cold injury, we want to know how long was the patient exposed for, what was the temperature, was there any wind, were they wet? All of these things are going to help us decide how bad is this exposure. So now, in the vein of a little bit of common sense, how do you think that we treat patients who have hypothermia and were exposed to some cold?
Slowly bringing back their temperature.
Yeah, we've removed them from the environment and we warm them up. One of the big things to keep in mind is never begin warming a patient up if there's a possibility that they're going to get cold again. So you find somebody and you're out in the middle of God knows where, and you have a long trip to the ambulance. Okay, well, I know if I start warming them up here, and then I have that long trip to the ambulance, they're just going to get cold again through that long trip to the ambulance, and their body's going to be calling on some things and increase its metabolic demand and probably make this patient sicker. So you leave them cold until you get them to the ambulance. You know, we want to take off any wet clothing. We really, and if our patient is truly in a hypothermic state, whether it's localized or systemic, we really want to take off their clothing altogether, because pockets of like space inside of our clothing can still hide some cold air. We're going to wrap them up like a baked potato. We're going to get our space blanket out of the ambulance, and we're going to wrap them in that, in that sort of tinfoil looking blanket. And we are going to wrap them in blankets and towels and things that will keep them warm. And we're going to turn the heat on in the back of our ambulance and begin to bake them like a potato. It is going to help to, as Alex said, warm them up slowly, but we're also keeping their ability to continue to get cold to a minimum. Frost nip is generally the beginning stages. Skin can freeze, but deeper tissues are less affected. It's normally the ears, the nose, and the fingers. Generally, it's not painful. Generally, it is something that the patient might not even recognize or realize right away. It normally will start to become a little bit more painful actually when they begin to warm up. This really is just being out too long in the cold, shoveling your driveway with, no hat covering your ears. This is frost nip. Our immersion foot is a bit grosser. That is not only cold, but cold water. This is common with hikers and hunters or people that just don't take good care of your feet. I'm someone who I carried a lunchbox with me every day to work, and there was generally more socks than lunch in my lunchbox because being all day with miserable feet is going to make me a miserable person. I don't like my feet being wet. I don't like my feet being cold. I would wear a pair of socks once and throw it away. People that wind up with immersion foot, their feet are submerged in cold water for a long period of time. And you know that pruny look you get when you're in a swimming pool for too long, or too long in the bathtub or whatever? Their entire foot from the line where the water was is going to look like that. So you'll see a pretty pale line of demarcation, and the whole foot looks just sodden and pruny and cold to the touch. And really getting them out of the cold and getting their feet dry is what's going to make this better. Moving on from frost nip, now we're going to talk frost bite. This is the most serious of all of our localized cold injuries. This is where tissues are actually frozen. This is where fingers don't really still look like fingers so much anymore. I mean, if you take a look at the tips of all 5 fingers on this person's hand, what do you notice about them straight off?
They look like they're dead.
Yeah, they're black and gross. If I could keep those, I don't know that I would want to. Those, the tips of these fingers are completely black, probably frozen straight through. They're probably solid like the desk that I'm tapping on right here. Normally they become gangrenous and they start to infect and rot because of all the permanent damage done by this freezing and the injury from the cold, and they will actually require amputation. When we see superficial frostbite, only the skin is frozen. So parts of the finger, even if you were to give it a little squeeze, the finger may still feel like a normal finger. When we're talking deep frostbite now, this finger is frozen straight through, and it's like the Thanksgiving turkey before it spends a few days in the bottom of the refrigerator defrosting. It is legitimately that kind of frozen. Our scene size up, pretty straightforward. Make sure that it is safe for you and other responders. Clearly, if it's too cold for the patient, it's too cold for the provider, so move as quickly as you can to get to a warmer spot. We'll start talking the safety of travel in the ambulance and those kinds of things. But this is assuming that we've already gotten there and we haven't crashed the truck on one of these lovely icy roads that the state doesn't take care of. Just caution, caution, caution all around. Our general impression is going to be the same. We're looking at the patient. Do we see any life threats? If we do, we treat it. We're going to evaluate our mental status. How cold this patient is going to depend on how poorly they will do on the mental status exam. Mental status will fall off the colder and longer that your patient has been exposed to the cold. I know that most of this stuff is pretty straightforward, right? But just keep thinking, if my patient still has a mental status and they're still behaving like a normal human, it's probably not systemic. If my patient's mental status has begun to change, we've probably left now the area of a localized cold injury and we are dealing with someone who is more profoundly ill and may require some more treatment, because it is very likely that we will find patients who have a systemic cold reaction in cardiac arrest. We're going to begin cardiac arrest management if we cannot detect a pulse on these people. We're still going to concentrate on airway, breathing, and circulation. Our primary assessment is where we are going to live with them. We are going to do our best to warm them back up, but our primary assessment is going to be the meat and potatoes of what we do. We are going to initiate all forms of cardiac arrest management, which may include defibrillation. We're still going to defibrillate. Whether it will or it won't work has been a topic of much debate for a really long time. But if you get a shockable rhythm, provide a shock to this patient. This is another mixed bag as far as what we can expect and how sick the patient will be, and whether or not the patient improves, whether the patient gets worse, is going to depend a lot on a lot of factors that the patient has exposed themselves to, and some factors that we're going to expose them to. They're all going to require immediate transport, but we need to be aware of and on the lookout for a patient who already appeared lifeless, right? Think of how difficult this is going to be to figure out. Your patient already appeared lifeless. You had to, for 60 seconds, try and count respirations and try and count heart rates, and you could just barely palpate a carotid pulse or any chest wall movement. And now you have to try and stay on top of the fact, did my patient just go into cardiac arrest? So go slow with these patients to try and avoid that becoming an issue. If you had a patient who appeared lifeless, took you a long time to figure out that yes, they had a slow heart rate, yes, they had a slow respiratory rate, they still have one. So go about your business a little bit more methodically. Don't rush. Take it easy bringing them to the emergency room, because rough handling is a very, very big trigger for sending these patients into cardiac arrest and really kind of taking away all the good we did in warming them up and doing as best we can for them. We're going to focus on how long and how cold. We're still going to do all the rest of the OPQRST, but how long was the patient in the environment? Think of all the things that make sense to ask somebody if we show up and they've been frozen or fallen through some ice and now they're wet and cold. All right, well, how long were they in the water for? How long have they been out in the cold for? How cold is it? How windy is it? How cold was the water? Because 32 degrees is 32 degrees. The longer someone is in cold water, or the colder the water is going to make that much more difference in now how insulted is their body by how negative this reaction is. Here's our general guidelines for caring for these people. Well, let's call this the common sense department again. Move the patient from the cold environment, remove any wet clothing, place dry blankets over and under the patient. We can wrap them up like a burrito in as many blankets as you can get on top of them and begin warming them up. If at all possible, we want to start giving the patient warmed, humidified oxygen. Now, humidified we can do, but warming in our capacity is going to be a difficult task. The best we can do is keep the environment warm. We will keep the heat in the back of that ambulance set to barbecue or rotisserie. So crank up the heat in the back of the truck. We don't want to massage the extremities. Why would we not want to sort of massage the extremities and try and get blood pumping around?
Probably because it would be real painful for the patient.
That's as good a place to start as any. It's first of all, it's going to be painful. Why do you think it'll be painful?
Because those areas are frozen, probably.
Yeah, those areas are frozen. Those areas are damaged. The last thing we need to do is go now rubbing and massaging and causing more damage. Not to mention all of those things that are inside of those damaged cells are supposed to be inside of those damaged cells. If we start breaking them down with a nice, solid massage, thinking we're doing the right thing, we cause the same thing as anaerobic metabolism. Those cells eventually break down, they explode, they spill their contents, and now we're perpetuating the problem. Nothing to eat, nothing by mouth, nothing to eat, nothing to drink for these patients, period, end of discussion. We don't really want to give much by mouth to anyone because we're always concerned for airway. These patients are no different, so no coffee, no tea, no, warm cider, no tobacco, no alcohol, none of those, tried and true old wives' tales. As soon as they call 911, we're going to warm them with the environment we move them into. We're going to warm them with all of the additional layers that we can put on top of them once we get them out of their cold clothing. And that's the way that we're going to continue their treatment. So place the patient in a warm environment, remove wet clothing. If my patient is still conscious and alert, we can apply heat packs to the groin and the axilla or the cervical regions. Think places where large arteries travel close to the skin. Now we're trying to warm them from the outside. We're also going to try and warm that blood and warm them from the inside out. Now, again, remember, the difference between national and what you guys are actually going to do as providers in the field. The book says we can give them warm fluids by mouth. So go with that if you're in front of a computer. But really here in the great state of Massachusetts, we're not really doing much giving people anything PO or anything by mouth. Our moderate to severe hypothermia patient, it says right here, this top bullet point, do not try to actively rewarm the patient. So what do they mean by actively rewarm the patient?
Probably too fast to a normal body rate temperature of 98.6 degrees.
Right. So let's take a look at some of the rewarming things we already talked about. And what on here seems active?
Like the heat packs?
The heat packs, you got it. So if we're not going to actively rewarm this patient, we're going to prevent further heat loss. So we remove them from the cold environment, take their wet clothing off, cover them with a blanket. It is okay to put them in a warm environment. What we're not trying to do is apply things to them that are going to warm them up. That's our active rewarming. Generally speaking, our moderate to severe hypothermia patient, what do you expect their mental status to be?
Deteriorating.
Yeah, probably already deteriorated. They are going to be questionable at best whether they could tell us whether we were actually burning them. So that's why we don't actively rewarm. Our moderate to severe hypothermia patient, we just rewarm with the environment we put them in. Our mild hypothermia patient, we can go ahead and apply those hot packs to. Our local or cold injury is going to be pretty much exactly the same stuff. We want to remove any wet or constricted clothing. We want to handle the injured body part gently. So gentle is the nature of the beast here when we're talking about cold injury. Now we're going to get into the weeds a little bit here because I'm going to tell you something coming up on the next slide, and then we'll talk about how on earth they expect us to be able to do this. But we're still not going to rub and massage injured tissues. We're not going to re-expose them to the cold. If it's cold and wet and we're thinking trench foot or immersion foot, we want to take off the boots, take off the socks, get any wet and cold clothing off of them, and then begin to rewarm them. Now let's talk for a moment about rewarming in the field. So here's our rules of engagement here for this. We're going to somehow get a whole bunch of water. We're going to heat it to 102 to 104 degrees Fahrenheit, constant temperature. So that means it has to stay between 102 and 104 degrees Fahrenheit. And we are going to immerse the frostbitten piece in that water that is 102 to 104 degrees Fahrenheit. Now I want to ask you guys a question. First of all, where am I going to get the vessel that I put this water in?
Definitely no idea.
My next question would be, how am I going to heat this water and maintain this water at 102 to 104 degrees Fahrenheit? And then how am I going to transport this contraption to the emergency room? Let's just do things that make sense, right? Massachusetts has actually taken this out of the protocol as well. Because don't you think it's a whole lot easier to dress the area with some dry, sterile bandages, try not to break any blisters that have formed, because that's blood plasma that's actually been frozen out of the cells and out of the tissues, and we want to try and keep that inside the patient. And we just don't let them get cold anymore. Because when we get them to the ambulance is going to be warm. They're going to be covered in blankets. They're going to be wrapped up like a baked potato. So keeping their body warming them up and letting the ambulance warm them up. Because how on earth we're supposed to do this is absolutely beyond me. I don't know where we're supposed to get any of this stuff. I don't know how we're supposed to accomplish it. And it really doesn't make any sense, because how am I going to bring this nice 102 to 104 degree bucket of water to the emergency room? You know, we'll put a pan on the stove and we'll just keep pouring warm water from the stove into a trash barrel, and we'll somehow figure out a way to, you know, get a thermos or a couple of thermoses. Some stuff just doesn't make sense. We work in an urban area. We can have this patient to the emergency room in no time flat and not really have to worry about any of this kind of stuff. So now we're getting to the other end of the spectrum. The body is going to do its level best to maintain a body temperature of 98.6 degrees. It will begin to sweat. It will begin to dilate the blood vessels. It will do whatever it can. Now, mentally, we'll talk of removal of clothing or driving you to move out of that hot environment to maintain that body temperature, because we don't get a whole bunch above 98.6 degrees of core body temperature, and we see some problems starting to develop. And the way that the heat overcomes us is very, very similar to the way that the cold overcomes us. High air temperature is going to reduce radiation. So if the air temperature is higher than body temperature, my body is just not naturally radiating away that temperature. So all of that's coming to me. If it's very, very humid in the air around me, evaporation starts to fail. So all the sweating in the world does nothing but make me soggy. And if that first line of defense against the heat for the body is something that is not working because of high humidity, the body is already losing and starting to maintain heat. One of the big ones is lack of acclimation to the heat. This is something we see very, very early in the summer. People aren't used to those, 90-degree temperature days with 70, 80% humidity. And this is something that needs to be sort of taken into account in the early days of summer. The other thing we'll see a lot of is vigorous exercise causing fluid loss and causing electrolytes to go away. Not only are the electrolytes really important for a body's ability to maintain and continue all of the processes of life, but electrolytes are salts, and salts will actually help us maintain our intravascular fluid. So if we're sweating from vigorous exercise and we lose a lot of fluid in general, this is another one of those non-hemorrhagic hypovolemic shock type situations. And let's have a look and see who our most susceptible folks to this are. Wouldn't you know it? Really young, really old, people that are already sick. These are the three categories of people that are most susceptible to most things. I'm going to go out on a limb here and say probably most of us have experienced these first two problems. Heat cramps are just that. They are those painful, like Charlie horses you get generally in your calves or in your hamstrings. It's not just a result of high temperature. It is a result most of the time of fluid loss. And that fluid loss causes the muscles to cramp, causes the muscles to spasm. They don't have a 100% handle on what exactly the where's, what's, and how's, but they know it's normally in the legs or abdominal muscles, and it doesn't have to be like raging hot. Heat exhaustion is really going to be the most common thing we see. Heat exhaustion is up until the point of your patient losing consciousness. Our heat exhaustion patient will generally be tachycardic. They will still be sweating. They may be hypotensive. Why do you think they would be hypotensive? Anybody? What's one of the big problems with heat? Is loss of fluid and electrolytes. That's why one of the big things we'll see in a patient who's got heat exhaustion will be hypotension. Our patient won't have enough circulating blood volume to actually maintain a decent blood pressure. They may actually have a syncopal episode just because they are unable to maintain that blood pressure. And then we get to the wicked stepsister, heat stroke. Heat exhaustion is very, very common. Heat exhaustion is quite simply just overdoing it in the heat. Heat stroke is a whole lot more profound. Heat stroke is someone who their body has been overcome and overwhelmed by the actual heat and has lost its ability to now do anything to deal with this. Heat stroke, our patients are generally still warm, they're generally still tachycardic, they're generally still hypotensive. What do you think the one difference between heat stroke and heat exhaustion typically is that we'll see. Our heat exhaustion patient is still going to be sweating. Our heat stroke patient is generally going to be dry as a bone. Why do you think that is?
They already went through all the sweat.
Fluids to sweat.
Yep, they've already burned it all away. They don't have the fluid left in them to actually accomplish the work of sweating. The body has been completely done over, and it is just not going to be able to do it anymore, and it doesn't.
So heat stroke is the one where the body physically can't cool itself any further.
Yep.
Okay.
We'll see this a lot of the times. Sure, physical activity, vigorous physical activity. We'll see this a lot of times in poorly ventilated areas. We'll see this a lot of times in heat waves. Heat waves is the time we'll see this because the body doesn't have a period of being able to gather itself back up and, you know, restore all of that lost fluid. So then tomorrow, when it's 100 degrees with 100% humidity again, it's like being in that hot car all day. It is poor ventilation, poor ability of the person to actually now replace all of the things that have been lost. And it just continues to stack on itself and stack on itself and continues to get worse. If the body doesn't have a period of time where it's able to actually recover, we're going to go from heat exhaustion early to heat stroke over a prolonged period of time.
Tommy, quick question.
Yep.
When it comes to hypothermia, you slowly warming them back up. When it comes to heat stroke, is there any contradictions to rapidly cooling them, like dumping a bucket of water or something on them?
So there is. If you think about how much the body is really sort of under duress at this point, doing something like that is going to cause them to shiver. Causing them to shiver is going to also do what?
It's causing them to produce
Shock.
They're
It's
gonna
going
make.
to cause
They're
them
gonna
to
try to make
stop
heat.
producing heat.
Okay, that makes sense. Thank you.
No problem. Patients with hyperthermia are very often going to present like this. And we're going to see one very clear line of definition between hyperthermia and heat exhaustion and hyperthermia and heat stroke. They're going to be tachycardic and tachypnic, so high heart rate, high respiratory rate. Their blood pressure is generally going to be low or trending to the low over time. So we're looking at signs and symptoms of shock. In heat exhaustion, our skin may be normal, cool, or clammy. In heat stroke, our skin is going to be hot and dry because the body has burned through all of its cooling mechanisms. The body has burned through all of its excess fluid, and we're going to now no longer be able to be in normal body temperature. We're no longer going to be able to cool ourselves. We're no longer going to be able to sweat because there's no more of that available. Instead, we're going to now start retaining heat, not have the fluid to dissipate any of it, and the patient is actually going to be hot and dry in heat stroke. We want to be careful not to overcool our patient. We want to check every 5 minutes because it is quite likely that this patient will deteriorate and deteriorate rapidly. What's our management? Get them out of the hot environment. Give them oxygen as indicated. We want them to lay down or sit, position of comfort, and we want to cool the patient. Now, we want to cool them gently. the common sense thought is we want to cool them off. We need this patient to cool down quickly. I can see why dumping water on them seems like a great idea, but we want to spray water on them. How come?
Because their body's overheated and exerted all their supplies to support life. That you've given too much. It's the same thing as the opposite of hypothermia. They're gonna go into shock, and it's not gonna gradually bring them to the temperature they need to be.
Less
Right.
of a shock on the body.
Right, and we're using some of that conduction, convection, all 5 of those sources where the body loses heat. We're actually assisting that by cooling them down and wetting them down sort of slowly. We don't want them to ever get so cool that they begin to shiver, because then we're fighting the battle on 2 fronts, and which came first, the chicken or the egg? You know, sort of wet sheets and things like that, and some air in the back of the truck is going to be where it's at for these people. Our heat stroke patient, on the other hand, their body is no longer involved in this argument. Their body is no longer going to put up with the insult that it has been exposed to. And these people, we need to cool down fast before the brain starts to cook. So our heat stroke patient, we're going to get them as naked as the day they were born. We're going to administer oxygen. We're going to assist ventilations. We want the ambulance AC set to maximum cool. We want to be able to keep meat in the back of that ambulance, because eventually the body's inability to cool itself will actually sort of end in the brain and other organs being so damaged and so cooked by all of this retained heat that nothing is going to bring this patient back around. You know, and guys, I'm just looking to see what else we got ahead of us, because a godly percentage of this is all just the slides repeating to you things that are in the book. And I know you're reading the textbook, so let's have a look and see if there's anything overly pertinent here. All right, here's the deal. We're going to cover the rest of this chapter with some of the case studies and stuff when you guys come in to do skills this afternoon. It's a Monday, and everybody worked their butts off all weekend long, so we're going to call it a day here with lecture, and we'll cover all the rest of this stuff when you guys get in, unless I hear any